again, that's what that's what this diagram is trying to drive home, right? Is that also noting, though, too, that by cell thickness, the stratum corneum is by far the thickest layer of epidermis in the skin because, of course, it's going to have the most layers of cells in it. And that as you move down into the skin, what's trying to be represented here is that these layers of skin are increasingly alive, right? Or are increasingly not going to be deadened as they are going to migrate to the outer layers of the skin. But also what's being attempted to be demonstrated in this diagram too is that relative to the rest of the skin, the epidermis is much thicker than the dermis, and each one of these layers is going to be much, much thinner than any of the other larger layers of the skin, right? And so again, you have the epidermis, dermis, and hypodermis, and again, those 5 layers of the epidermis are going to all be contained within that upper layer of epidermis, which is relatively thinner than the dermis. Yes?
Do we know the layers of the epidermis?
Yes, absolutely. You want to know stratum corneum, stratum lucidum. You want to know that that's not always present, right, in particular areas of your skin, right, that it's only present in the palms of your hands and the soles of your feet. You want to know stratum granulosum, stratum spinosum, and stratum basale. And that your stratum basale is where you're experiencing increasing division of your keratinocytes, which are going to be those cells that make up your skin, and that as they migrate further away from the dermis, they will increasingly die because, of course, they're migrating further and further away from blood supply, right? Because, of course, your blood supply is primarily located in your dermis. Or then similarly, if I asked you if you puncture yourself and you begin bleeding, you punctured at least into what layer of your skin? The answer, of course, is the dermis, right? Because, of course, your epidermis is completely avascular because it's all made up of stratified squamous epithelium, and as we know, that epithelial layers and epithelial tissues are avascular themselves and rely on the lower levels of tissue to feed them, right? To feed them their nutrients that they need. So again, as these cells migrate further and further out to the outermost layers of the skin, they increasingly become dead. Okay. No melanocytes are found in the stratum basale. Note that they're secreting melanin, and that melanin is packaged into melanosomes. Note that dendritic cells or Langerhans cells are found in the stratum spinosum of the epidermis. Merkel cells are found in the stratum basale. Alongside the melanocytes are also found in the stratum basale, and your corpuscles are actually found in your dermis. And again, although I'm not going to ask you to label this diagram, I think pretty much every bit of information in this diagram is something you should know, right? You should know that sebaceous glands are associating with hair follicles primarily, and that's usually what we mean when we talk about a pore in our face, and usually we're talking about hair follicles, that the pores of the sweat glands are separate from the sebaceous glands, and that they are going to release directly onto the skin. We should know that there are 2 types of sweat glands, right? Eccrine and apocrine. Eccrine is much more common. Apocrine only found in particular regions of the body. You should know that the dermis is where you're going to find your blood vessels and your nerves. Let's see, your rectopili muscles are a type of smooth muscle that's going to pull on the hair to, of course, cause the hair to stand on end. Sebaceous glands are going to take advantage of holocrine signaling, where again whole cells are going to be released as part of the secretion of the secretion of that, whereas eccrine sweat glands are going to release via merocrine secretion, and apocrine sweat glands, of course, release via apocrine secretion. Right? That's why they're called apocrine sweat glands. Right? Again, your hair bulb is going to be inside of the hair follicle, which is at the base of the root of the hair, and then of course the shaft is all of the area that projects out of the skin, right? And that's going to be primarily dead and keratinized tissue that of course is sort of projecting out of the skin. Again, there are going to be different phases of hair growth, where again the hair grows from the base of the hair and sort of begins to migrate up and out through the hair follicle to, of course, allow hair growth to occur. Yeah, and hypodermis, of course, has adipose tissue in it. Is going to have functions in both preventing mechanical damage and providing a certain pliability and in sort of pushing on the skin, as well as will help maintain internal temperature by providing a layer of insulation. Anything else on the diagram we're unfamiliar with? Dermis. Yep. Yeah, we should know that a papilla, right, is that little projected upwards area in the hair follicle that has a direct contact with blood vessels. That's going to provide the blood supply. Papilla, yeah.
And the papilla has direct blood supply to the hair follicle?
To the hair follicle, yeah. At the base of it, yeah. Because remembering that, again, those cells need to be alive, right, so that they can divide, so that that's what fundamentally what causes hair growth, right, is the division of those hair follicle cells at the base of the hair that, of course, allows it to grow outward.
Okay, and which one of those layers of the skin, so like they're not, is something always there?
Oh, stratum lucidum. Stratum lucidum only found in the palms of your hands and the soles of your feet.
Okay.
Yep. Anything else on the diagram we're uncomfortable with, we don't get? Yeah, I would focus pretty heavily on this diagram. Again, you won't be asked to label it per se, but be sure you know all of these parts and how they work. This would be a diagram to focus on for sure, because it has a lot of information in it regarding, again, where these structures are and what they're doing. And again, if you can identify what each of these structures are and what they do and how they do it, you're doing pretty well for discussing overall function of the skin. Again, we talked about this, and again, the same diagrams, no sebaceous glands, right? Again, sweat glands, we talked about eccrine and apocrine glands. Again, we talked about the overall major parts of the hair. Again, knowing those, hair shaft is going to be the area projecting out from the skin. And again, the hair bulb at the very base of the skin, and all that fitting inside this structure called the hair follicle, right? Yeah, know your three layers of hair. Your medulla is the center, your cortex is the outer side, and your cuticle is the outermost layer. Cuticles become increasingly damaged at the very tips or ends of the hair, which of course causes split ends, right? Again, here's your papilla, right? This diagram I wouldn't nearly focus on the details as much with. I would know more so the next piece here, that the hair grows in different phases, and that again, that growth is enabled by the fact that there is blood supply to the base of the hair follicle, so that those cells can remain alive, and that as they are alive, they continue to divide, and that as they divide, that'll cause growth, right? That growth is occurring in these three phases, right? Nails, again, not the particular details. I would know certainly what the hyponychium and eponychium is. Again, the hyponychium. Oh, okay, there we go. The hyponychium, again, is going to just be that area where you accumulate dirt and dust and debris underneath your nail. That is between the free edge and the actual skin sort of beginning of the nail. And then the eponychium, of course, is going to be that area of nail that's going to begin to extend into the nail root, where again the nail root is going to have alive cells in it that are going to be filled with hard keratin, and again that hard keratin is going to form that hard outer covering of the nail. Rather so, of course, your nails will have the features that they do, right? They're going to grow from the root of the nail and grow outward. Again, the free edge is going to be the distal most part of the nail, and there are going to be a lot of capillaries present in the nail bed, which is, of course, why it has that pinkish coloration to it. And again, of course, the cuticle are going to be those folds of skin that come near the eponychium and sort of encase it or enclose it, so that, again, nail growth is going to occur from the base beneath those skin folds in the nail.
The cuticle has another name.
Eponychium.
Do you know the other name?
Yep, no eponychium. Eponychium, also known as cuticle. Know your different types of skin cancers in A, B, C, D, E. Asymmetry, borders, color, diameter, and evolving is the shape changing. And that's how you begin to identify different types of skin cancers. Now this diagram, know that, again, burn severity corresponds to the layer of skin that's been damaged. And here's your rule of nines that, again, your back and your front of your arm are 4.5 itself, so the entire arm is 9. And I think I got this wrong when I was describing to you. The entire head, both back and front, are considered to be 9 altogether, and I think that gives you your 11 areas. 1, 2, 3, 4, 5, 6, 7, 8, 9.
You had the front and back of the head is 4.5, it all adds up to 11.
Is that right?
Yeah.
Yeah, okay.
Yeah, because the head.
Yeah, right, because note that the arms and the legs are different, and that the entire length of the leg in the front is considered 9, so the entire leg itself is considered 18.
That's right,
Yeah.
yeah. The back and front of the leg is 9.
Right. So, yeah, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11 is the head. And then, of course, the pubic region's the remaining 1%. That adds up to 100. So that's just the one to note, that this diagram is completely correct except for the head. Again, the front of the head should be 4.5, the back of the head should be 4.5. Or again, the entire head is 9. So, and also to remember that one of the severe risks relating to burn is dehydration, right? And that's because, of course, as the skin becomes increasingly damaged, it's unable to hold water into it. Because, of course, we've removed those mechanisms that normally keep water inside of our lower levels of tissue. And we didn't go over a lot of that stuff. Again, I would suggest that potentially you use these to your advantage too. You have these case studies in the back here. If you could describe each of these case studies and why, why they're affected, you should be doing pretty well with the exam too. Because again, that's largely what we're aiming for, right? Is if we see an abnormality in the skin, we should be able to describe the reason why we're seeing that abnormality. Which one do you want to go? Yeah, Anita?
Sorry, go back to the hair.
So depending on what you mean by that, if you need to know, do you need to know all this? No.
Yeah, but I'm asking, like, you need to know, like, the epidermal sheet, the dermal sheet.
Right. No.
Oh, no?
Yes.
Okay, so just the...
Not all the details. Again, you'll need to know things like the papilla is where that blood supply comes from, and that it needs blood because those lower layers are living, right? And that's what is required in order for them to divide. So that that we do need to know. This we need to know for sure. Yes, this we do. But this not so much. Again, not all these details, right? I mean, we should still know the papilla, right? We should still know that these lower layers of cells are living. But again, identifying each of these sublayers and whatnot either, I don't think that's as important to our purposes. Or that similarly, the erector pili muscle is pretty well established in this diagram too. We should certainly know that the erector pili muscle is present. It's a smooth muscle and it's involuntarily going to respond to cause our hair to stand on end. And what's more commonly referred to as the goosebumps response, right? So quickly, the one is that if a patient in her late 70s enters in the ER unresponsive and if she looks cyanotic, what's the problem? Why? And what do you want to do to help her out?
Oh, she's lacking oxygen.
Yeah, she's literally turning blue or purplish, right? As a result of the fact that her hemoglobin isn't oxygenating appropriately. Which is a sign of cardiovascular complications. So you might check her airway first, right? Make sure she's not choking on anything or whatever either. And then you potentially want to get her oxygen somehow, right? Either through CPR, unless she's DNR, in which case you might just provide some palliative oxygen to see if that brings her out of it. And if not, that's the way it is, you know? Like, that's what we have to do. But that's the situation there, is that, yeah, she's having trouble breathing, because that's what cyanosis is indicative of, is that the hemoglobin isn't oxygenating appropriately. So those are the sorts of things you're identifying. Oh, this is one I like. Rex, 23-year-old college student, comes into the ER. Looks very yellowed and complaining of pain in his right hypochondriac region. And upon taking history, you've learned that he's recently on spring break. What's Rex's problem? He's a party boy, right? You've been hitting it too hard out in spring break and whatnot either. And he's also a 23-year-old college student, suggesting maybe he's a super senior, right? In his 5th year or something like that. But yeah, that's his problem, right? Is that he's beginning to jaundice because his liver has been so extensively damaged from all the partying he's been doing, at spring break. So of course you want to place him on an IV solution and begin to allow him to sort of filter out a lot of those toxins. So hopefully he can regain some hepatic function, right? And you potentially want to begin detoxifying him, however you might be able to accomplish that, right?
We did the second one.
Yeah, so if it's suffering from an acute allergy, so we have 2 routes of administration, transdermally or intraperitoneally. Which one should you go with in order to affect their condition? By transdermally, we mean literally we could potentially apply ointment or cream or salve to the localized area that they're having the allergy on so that we could reduce the rash. Or we could inject them with something into their peritoneum.
Yeah.
Okay, why, Ina?
Because it would react faster, and if it's straight into the peritoneum, it will
Why would it react faster?
It's going straight to the source where it needs to.
Why would a transdermal administration potentially not work at all?
Is it just, it's on the surface?
Where are those blood vessels, and how do we get to those areas, right? Is that depends on the nature of the drug, right?
Mm-hmm.
The drug is dissolvable in water, let's say, or polar, right? We're trying to get it through a bunch of layers of cells. What's the problem with that? Membrane's non-polar, right? In the interior portion of it, right? And so absolutely that if we applied the drug, then potentially it wouldn't get into those lower layers of tissue, especially because at the lowest layer of the skin, we also have this especially non-polar tissue we call adipose tissue, right? And it's filled with a bunch of non-polar molecules and stuff too that very especially keep things out of being able to be absorbed out into the lower layers of tissue, right? So although we could get some administration in through the bloodstream, perhaps in the dermis, if it was nonpolar enough to get into the dermis, if we get it into the peritoneum is directly served by blood vessels and things, right? So potentially then we get it taken into the bloodstream a lot quicker because we're injecting it directly into the bloodstream through the contact the peritoneum has with blood supply, right? So that's what we're going for there. Is that the transdermal administration might not work at all, whereas intraperitoneal injection would likely get it into the bloodstream, where then potentially it could have its effect on things like the lungs, right, and the blood vessels in other areas, right. And that's directly relating to the third one then, right, is that if you're designing a new drug and your colleague says that they want to hit the receptor a lot better by adding a lot of hydroxyl groups or alcohol groups to the drug, why are you concerned? Same reasons, right, is that adding those hydroxyl groups increases the polar nature of the compound, right? And if it's increasingly polar, it's less likely to be able to get through those layers of membrane to, of course, have its effect. So potentially you want to actually increase its nonpolar nature simultaneously as adding those hydroxyl groups to potentially then increase efficacy. Again, so that just gets into that idea that we have to think about these things when we design drugs and decide how we're going to administer them, is because all of this other chemistry can affect then the drug's activity as it's administered in the body. Anything else? So yeah, I would say then, like, of the diagrams here, I went through all of them pretty extensively, but this diagram, or this diagram in particular, is the one to focus on because it has a lot of summarized information in it too. But then do note as well, the most I would focus on are both that one and this one, right, where you know those different layers of epidermis and be able to identify all of the cells and structures in each one of those layers, right? This one is supposed to be representing a dendritic cell in the skin. Okay. Endocrine system. Know what endocrine means? That would be a good start, yes? Or endocrine secretion is that it's a secretion out into the bloodstream, right? We've talked about the fact that then it gets into the bloodstream and it goes to different organs in the body. Why doesn't a hormone have effect on every tissue in the body if it's going out in the bloodstream? It has to have a receptor, right? Is that, yeah, exactly. And if it doesn't have a receptor, there's no effect.